KDOW.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation. 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group thewaytomyheart.org in partnership with Abbott. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of The Way to My Heart, Kim McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Leg pain, leg cramps, cold feet, burning, tingling, even foot ulcers. If those symptoms are yours and you have been listening to this show for a while, you would think you have peripheral artery disease or restricted blood flow in your leg arteries due to plaque buildup. But if you don't have plaque buildup in your leg arteries and you still have restricted flow, what might it be? Well, over the next hour, we are going to answer your question and tell you the critical questions you need to ask your doctor to get the right diagnosis for you. We have Dr. Krishna Mannava. He is a doctor over in Ohio, and he is going to be joining us today, Dr. John Phillips, and we're going to be talking about a disease that might mimic peripheral artery disease. And I'm not going to tell everybody what it is as of yet. Got to stay tuned.
Yeah, wait. This is going to be a good cliffhanger.
Cliffhanger.
I love it. You know that is the well. So first of all, welcome everyone. Hope everybody's having a fantastic Saturday. Kim, I hope you're doing well. Krishna is a good friend and colleague, and I think this is the first time I've had we've done an interview and someone who's like literally down the street from me, I think. And so it's always nice to have that Ohio connection. But yeah, interesting topic. I think it's a little bit probably underdiagnosed. It's often seen in I'm not going to give it away, often seen in younger people who are more, athletic and stuff. So, and definitely as opposed to what I do as someone who works with needles and balloons and stents and things, requires a surgical intervention. Dr. Mannava is a vascular surgeon, so right in his wheelhouse. So it'll be a good conversation.
Mm-hmm. I think so. And you are on call, so you might pop in and pop out. You have some piggies you might need to save, or actually even full lives. I mean, usually, especially going into the 4th of July holiday, it is seriously, it is hot in so many different areas. They're talking out here in California, possible record-breaking temperatures, a lot to worry about. So I would imagine you might see some stroke patients and the like.
Well, yeah. So obviously, if it gets warm, we have to make sure folks who have underlying cardiovascular issues, particularly coronary artery disease, are well hydrated. When it's hot and humid out, the arteries kind of open up, They dilate, and people who are on blood pressure medications that we want to lower their blood pressure can then get exaggerations in that decrease in their blood pressure, which can cause acute coronary events and things of that nature, which is why, we caution people sometimes for, jumping in hot tubs and things of that nature. But yeah, we've already had one heart attack this morning, and hopefully he's doing well. Hopefully we don't have any more, but you never know what's going to happen at Riverside Hospital in Columbus, Ohio.
No, and especially during the summer when you're on call, it's one of those things where, yeah, you're on call, but you're actually going to be working because so many things happen during the hot weather that could lead to some sort of vascular or cardiovascular event for so many different reasons.
Yeah, and it's kind of interesting too, because folks are traveling. And so one of the gentlemen that we saw, he lives in Florida, he's visiting his son. He had a heart attack. The cute little old lady that I saw this morning who needs a little work on her legs. She actually lives someplace, I can't remember, it's fairly south of here, but was visiting her boys, and she broke her ankle and then was now having to rehab locally, and then developed an ulcer. And, it is what it is. At the end of the day, you try to take good care of folks and help them wherever they come from. And just like Dr. Mannava, we do a lot of work with folks with peripheral arterial disease, and some that don't have peripheral arterial disease that mimic symptoms of peripheral arterial disease, which we're going to touch on here real shortly.
It's interesting because you're in the hospital, you have those on-call duties, and I'm curious with with Dr. Mannava. Dr. Mannava, do you have on-call duties at a local hospital? You have your own office-based facility, and that's typically, well, 9 to 5 during the week, they claim, but you also, have your 24/7 call service in case one of your patients have any sort of complications that they need to discuss with you. But you don't have to actually do it for a regular hospital, do you, as well, where you have to go in?
Yeah, so well, first, thanks, Kim, and thanks, John, for having me on. I really appreciate it. I've been looking forward to it. So this should be fun. Yeah, so I am a vascular surgeon. I do have my own private practice. I have my own freestanding office-based lab and now a surgery center. But for years and years, I worked primarily out of a hospital. So I still have a strong connection to a local community hospital where I do take regular call in the mix with a couple of other vascular surgeons. So yeah, so every third weekend and essentially a third of the time I'm on call, but I'm on call every single day for my own practice and my patients. Unless I'm and sometimes, John, even if you're on vacation, you still get called.
And that's where I was a little bit, there was a little bit of sarcasm in there because people think that because you have your own private practice that you don't have any on-call duties. And I find CLI fighters such as yourself and such as John Phillips, and even if John was in a private practice, he would still be, just as you, taking calls 24/7. I mean, 7 days a week. You guys are really passionate about your patients.
Well, we're wired a little bit the same way in that, yeah, you have ownership of your patients. You have such a good relationship with them and trusting their care to you. And then for you to hand that off to someone else who doesn't know your patient is difficult. And some of these people, as John knows, they've had numerous procedures over the years, and who better to if something were to happen. And then plus, you don't want someone like that landing on your lap if you've never met a patient. They've been taken care of by a quote unquote outpatient vascular specialist, and suddenly they show up in your ER. It's like, so yeah, it's you have to kind of figure it out. It can get complicated, but ultimately you do the right thing.
What's really nice, though, is I find with our circle of CLI fighters around the world is that even if a particular CLI fighter has a private practice, if they have a relationship with someone, with another CLI fighter within the practice, I always find that the two call each other. And I even had heard that you both were on the phone this week, which was music to my ears as we were leading up to this show this week, where you both were going to be on for the first time together in an interview setting. But they'll call each other, and the person in the hospital says, hey, you know what, your patient just came through the emergency room. Anything that I need to know about this patient? And I think that that's fantastic. It's a definitely a patient-centric approach.
Well, let me just say this. Although, Kim, I've got a fantastic quote that I've been working on here, but nonetheless, we'll get to it. But I will just say this because I think it's important that we have a conversation with somebody who has a highly functioning office-based lab that now is going to be pivoting, and correct me if I'm not wrong, Krishna, into a ambulatory surgical center, so he can do more procedures and things of that nature. But the OBLs, as the acronym, have been maligned pretty heavily of late, and it's important for us to, I think, recognize ones that do a good job. And I can speak from experience. Krishna does the right thing, and there are some out there that don't necessarily always do the right thing. And not to throw anybody under the bus, but I think it's important to, at some point during this conversation,
ladies and gentlemen, boys and girls, we got to go to commercial break. So you're going to hear more here on the Heart of Innovation on KDOW. We'll be back soon.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thank you for joining us. I was about to pay my friend and colleague, Dr. Mannava, compliment before I was so rudely cut off by our wonderful producer Colin. But as I was saying, it's important to recognize people that are doing it right in the office-based space, as well as now in the ambulatory surgical space, because these procedures that we do in the hospital can be done oftentimes for less as it pertains to cost for the patient and kind of general overhead. And if they're done correctly, patients have a fantastic experience. A lot of times folks that come to Riverside, great facility, but they get lost parking and this, that, and the other. So there is a convenience for the patient. And I hope that moving forward, our the societies that we work with and the physicians that do the procedures we can all kind of pull the rope in the same direction and kind of keep these places alive, as opposed to potentially having them close. Because I know, Kim, we've talked, there's some friends of ours and college people that they've had their office-based labs closed for various reasons. So at any rate.
And what's interesting in the particular case we're going to get to with the disease that we have yet to mention still, ... It was a situation where we had put this person in contact with a hospital and with an amazing CLI fighter, because I was thinking maybe the hospital, because they weren't sure, and there were some other things that made me think maybe a hospital might be better for this patient. But then the physician ended up getting, stuck in some politics and all this stuff. In the meantime, based on the criteria I told this patient they should use in finding a doctor, lo and behold, this person went and found Dr. Mannava. And he was able to get this patient in literally right away, which shocked this patient. So before I connected right back with her, she had already had the issue taken care of for the most part. And I was like, whoa, it's just been days since I talked to you last. So there are these benefits to some of these other facilities that may not have the red tape that patients have to jump through, in order to get seen by the physician right away. And so for Krishna here, he was able to get this patient in right away, get the issue taken care of, and get this patient back on their feet, and with some serious symptom relief right away.
Yeah, 100%. I mean, they're nimble enough, and at some point we'll let Krishna speak.
I know, we're having a great conversation about.
If anyone's still listening, we'll see. But no, yeah, I mean, they're nimble enough where they can get folks in the same day.
Yeah.
And just the way we're structured here, there's a call center and there's scheduling that's centralized, and I mean, it's just an easier way to some degree for patients to get access. So I'm all for an OBL when it's done appropriately and good care is taken of the patient, which Krishna does. So kudos.
Fantastic.
Well, I appreciate
we're going to get to
Thank
him.
you, guys.
Yeah. we're just blowing you up right here.
Yeah, I know. I don't fit. I don't fit in
the
Zoom camera anymore.
Well, John, we want to get to Dr. Mannava in a moment, but you have some words of inspiration before we get into the heart of this discussion and tell everyone about that disease that we've been hinting about, that everyone should know about, that may seem rare, but I think it's more the case that it's just underdiagnosed. And there might be a lot of people out there suffering. So let's get to that soonest. So first, your words of inspiration.
Dr. John Phillips, spectacular vascular moment of inspiration.
All right. So let's see. We're coming up on the 4th of July, celebrating the birth of this wonderful country. Before we went on air, we were talking about, I caught a little bit about microbrews. And I think probably one of the oldest, it's now not really a microbrewer anymore, but it was at one time, Sam Adams, right? So I thought, all right, let me see if I can dovetail, right? The 4th of July, a freedom fighter, and then microbreweries. And so I got a quote from Sam Adams, which is kind of interesting. And I think that it really speaks to what the minority of us do in the sense of the passion for critical limb ischemia. And so Sam Adams is quoted as saying, "It does not take a majority to prevail, but rather an irate, tireless minority, keen on setting brush fires of freedom in the minds of men." Again, this is in the 1700s, but I like that quote. I think that's kind of fun. Like, the minority can prevail if they're tireless and they just never stop. And that's kind of what, actually, Kim, that's what you do. You're tireless and you never stop. The Energizer Bunny.
Yeah, we even had an emergency call this morning, from a patient in Canada. And so it's one thing after another, after another, after another. And so we just continue the good fight. I don't know as many doctors, everyone knows, in Canada, simply because they're not as, they're not in the public as much, as we see in other countries, especially in the United States. So they're literally a little bit harder to get to personally. And I end up having to go through the call centers like everybody else. But I'm hoping, crossing my fingers, I did find one of these doctors in a particular area on LinkedIn, and I'm hoping that he will be kind enough to get back to me so we can get this patient the care that she needs and the directives that she needs in order to improve her symptoms. So always a good fight. Love that quote.
Are you gonna tell me what the diagnosis that this patient has?
I know. We just keep you in the dark all the way up until it just makes it more fun with the free flow of the conversation. But I know that that Krishna here, who's with us, Dr. Mannava, he's also fighting the good fight, because it's also an uphill battle with him also trying to help a minority of patients, which actually are being underdiagnosed with something called, Dr. Mannava, do you wanna be the hero here?
Sure. So the mystery diagnosis is Popliteal Artery Entrapment Syndrome, PAES.
So that's a mouthful, Krishna. That's a mouthful. Tell our listeners what exactly that is and why it gets misdiagnosed so often.
Yeah, absolutely. So I'll try to keep this concise, because we can talk a lot and dive really deep. But normally, patients present to us as vascular specialists with typical atherosclerosis, plaque buildup in their leg arteries. But when you have a unique type of patient, a younger patient typically, who presents with similar symptoms to patients who have typical peripheral arterial disease, but they're young, immediately you start, red flags start going off, or they should. And so popliteal entrapment syndrome is one of the diagnoses that should come to mind in younger folks. So what happens is the popliteal artery, the artery behind the knee, as people develop congenitally, typically the calf muscle, your gastroc muscle, the medial, the inside half of that muscle can develop typically before the artery, or after the artery. And if the artery develops after the muscles develop, the artery gets pushed to the side by the tendon of the calf muscle, and it doesn't come to being significant until typically people are a little bit older and more either usually more athletic or more active. And when that muscle grows, that artery gets more and more pushed to the side or deviated. And that repetitive trauma to the popliteal artery behind the knee can lead to damage to the artery, either externally or internally. It can lead to clots forming. It can lead to the artery totally closing off, clogging off, or it can lead to showering fragments of clot to the arteries lower down in the leg or foot. And so in some people, they can be asymptomatic with popliteal entrapment for their whole life. But in certain folks, the artery can get severely damaged and lead to a lot of very limb-threatening complications.
Hey there, everyone. Dr. Krishna will be back here to tell you more about this disease here on the Heart of Innovation. You're listening here on P.A.D. We appreciate your time. We have to go to commercial, but I promise you more of the good stuff will be there. So stay tuned.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for staying with us. Before we went to break, we were discussing a diagnosis called Popliteal Entrapment Syndrome, and it's not technically peripheral arterial disease because you're not getting a buildup of kind of debris within the artery with risk factors to include diabetes or high blood pressure or high cholesterol. But this is just kind of the way you were made, so to speak, and over time you can damage that vessel. And so, Krishna, you did a fantastic job of explaining it. My question for you is, who's a typical patient? Because again, these folks typically don't have the risk factors that we look for, and therefore they may get kind of blown off as this isn't a vascular issue, it's fibromyalgia or leg cramps or something like that.
Yeah, it's a great question, and that's sort of the root of what differentiates popliteal entrapment from typical vascular disease is that it's really it comes from something totally different. So the patients we typically see are younger. Oftentimes, they're teenagers who are getting into athletics. So a typical classic example is a young 16, 17-year-old who's really training hard for a competitive sport, and their calf muscle has really grown rapidly, and that can trigger it or bring it out. So but we do see it in a little bit older, not older, but in people in their 30s, 40s, and 50s as well, for slightly different reasons. Maybe they're more active, maybe they're walking more. It's hard to say exactly, but overall, patients are younger, and oftentimes they don't have those risk factors that you mentioned. So they're not smokers, they're not diabetic, they don't have high cholesterol. So those are, all those things immediately should trigger a different thought process, for me anyway, on coming to a diagnosis when patients present with atypical symptoms and an atypical risk profile.
And you have a patient, we have a patient, one of your patients on right now. Angel, welcome to the show.
Thank you.
Great having you. Why don't the two of you kind of go over how the diagnosis was made? First of all, as I save my piggies portion, I always like to kind of hear your side of the story and the frustrations that you had before you had an accurate diagnosis and ultimate treatment plan.
Yeah, Angel.
Yes.
Angel, it's thanks for coming on, and good seeing you, by the way. Long time no see. Yeah, why don't you start? I mean, you came and you reached out to us, and the story is really compelling. So, we'd love to hear it. I mean, it goes back several months. So
yeah, it started in October of 2023, and I started having some numbness in my toes. And then I had like a lump at the front of my ankle. And then, but the numbness and the cold and the lump never was at the same time. So I did make an appointment with my primary care doctor in November, the beginning of November. And she's like, well, maybe it's just rheumatology, something autoimmune. You need to make an appointment with the rheumatologist. So it kept getting worse and worse, where I was, and everyone kept saying Raynaud's. And I was like, if one more person says Raynaud's, I am going to explode. Because I have been seeing a neurologist, neuro spine doctor, I've seen rheumatology, I've seen physiatry, I've seen cardiology, I've seen vascular surgery. I went to the hospital because I have sores on my feet. I've seen podiatry. I've seen every specialty that you could possibly see. And everyone just kept going back to Raynaud's.
So real quick, do you have any medical problems?
No, the only thing that I've had a hip replacement on my right side. I had that when I was 35, and then I had a hip revision when I was 36 on the same side. But nothing significant on my left side. Like it just all of a sudden just started killing me. Like my foot would go, I could not walk 3 minutes without, it was my toes. They would go completely white. It was like, I kept telling people I have no blood flow going to my foot. Like,
So,
what is?
exactly. So then let me ask you this then. So before you met Dr. Mannava, had anybody like done a real vascular exam on you to check your pulses at all, or no?
So yes, so I had seen vascular, never seen the actual vascular physician, was only the nurse practitioner. They couldn't feel my DP pulse. They couldn't feel the pulses at all. Barely
Felt
got
this
them.
was normal?
Oh, yeah.
Okay.
And so finally I decided, because she was like, well, the NP CTA came back and they said that was normal.
I said that was normal.
Mm-hmm, the CTA. So that was read wrong. The
Okay, I was gonna
bilateral,
say,
yeah,
because
the
I saw the blockage and I saw it. I'm not a clinician. I'm not a
yeah,
technician. I saw it
yes,
in the
yep.
imaging.
They said it was normal. And she's like, well, just come back and see the vascular surgeon, but you can't get into her until the end of July. And I said,
Oh,
no,
wow.
I can't do that. So I made an appointment with cardiology, and he was gracious enough to go ahead and do an angiogram. He did see that there was occlusions in my ankle, but he passed where he needed to go.
He
So
went down. So he came down from the groin. So he poked in, in the groin, and he took wires, down, down your leg.
yes.
And I don't understand. I have to have Dr. Mannava jump in. How do you miss that? Can you tell me from a doctor's person, how do you miss that going down? Because if he's going to see what's happening in the toes, doesn't he have to pass the knee first?
Yeah. So one, you have to have a little bit of suspicion, right? You have to kind of suspect this to really look at it. And then when you're doing an angiogram, you have to do some maneuvers, which they may have done, but you have
He
to
did.
target a certain area, the popliteal artery, and you really have to make the maneuvers extreme to really bring out the compression or the entrapment. So it can be missed on an angiogram, and definitely in Angel's case specifically, the arteries look normal when she is at rest. So a CAT scan, it would look
Oh,
normal.
wow.
Even though she has blockages down at the ankle or into the foot, the CAT scan is not good at picking those up typically. So
Really?
that's where
Why
sort
is
of,
that? That's interesting.
so as the flow is somewhat limited and there's blockages down that far down, CAT scans have some limitations, like especially if the blood flow is a little slow, the contrast wears out, and the arteries are smaller down at the ankle. So that's where CAT scans, MRI sometimes can be limited to look that far down the leg.
It's interesting because there are so many doctors that I've talked to around the world that say that they literally trust their CT angiograms like 100%. And they will not take a patient and put them on the table for a diagnostic angiogram that could include possible treatment if they saw something.
I hate to be the
Simply
villain.
because
I'm interested in the conversation, but these commercials are itching up on our back. So you're listening to the Heart of Innovation here with Kim McNicholas, Dr. John, and Dr. Krishna. We will be back right after these messages.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the show. We are in our Save My Piggies segment of the show, and we have Angel who's been with us. She's been kind enough to share her story. She has Popliteal Artery Entrapment Syndrome. It is a rare condition, but I think it's considered rare because it's underdiagnosed. And Dr. Mannava, over in Ohio, was able to diagnose her with it when all of the other doctors, including other vascular surgeons, cardiology, they all completely missed it. And before the break, he was getting into why it's misdiagnosed and how it was particularly missed in this case, when she went and had what we consider the holy grail of diagnostics, which is the CT angiogram. So many doctors I know say, hey, I'm going to decide whether I treat or don't treat based on that. But it's not until with this particular situation, especially, that you go in for a diagnostic angiogram and use intravascular ultrasound, or IVUS, I think in this case. During the break, you were showing us the imaging that showed obvious compression that was happening, doctor.
Yeah, so great points. A CTA is a great test, but it's a static test. And this is a dynamic condition. So you need a dynamic test, in my opinion, to really demonstrate it. So one thing that we can do is a non-invasive ultrasound test. So you can measure the waveforms of the arteries in real time while you're doing maneuvers to flex the foot or extend the foot to see if you can change the waveforms in the arteries and bring out the popliteal entrapment. So that's the first thing we did in the office, right, Angel?
Yes.
That kind of gave us a little bit of a clue. And then we said,
Krishna, you must have had some clue that there was something going on based on the CT. Did you see the CT scan or no?
No.
So your physical exam led you to believe, or did you just say I was going to do an angiogram just because?
No, because the clinical suspicion she had, so we put it all together, right? It's the whole picture. It's a healthy, relatively healthy patient who's younger, who suddenly has lost pulses in her foot. They did a cardiac workup in Dayton, so she didn't have a cardiac source of a clot to her foot. So then it's like, okay, well, then you start the differential diagnoses start getting limited. And so popliteal entrapment really moved up the list quickly. So that's when we did the ultrasound, and then we said, look, we got to do an angiogram. And there may have been some mention along the way, right, Angel, that someone maybe suspected it could be an entrapment syndrome.
Yeah, but they thought the entrapment was at the ankle. They thought it was something to do with the ankle versus anything higher up.
No, that's interesting. Yeah. So I haven't seen entrapment there. So anyway, so we scheduled it right away for an angiogram. And like Kim was saying, so we did a dynamic angiogram where we had her press really firmly against resistance. And that's where we could see the artery just completely pinching shut and no flow through to her popliteal artery. And then we did what's called an IVUS, intravascular ultrasound, and it was pretty dramatic, one of the most dramatic ones I've ever seen, where the artery just gets completely flattened like a pancake when she planted her foot. So right there, the diagnosis, it's pretty obvious.
Well, and Angel, I would imagine that was quite the experience, and a very different experience, being on the table with this doctor versus other ones and having to move around.
Yeah, it was very interesting. And I just loved the excitement with Dr. Mannava when he was seeing it and he was showing people. He was like, oh, like it's right there. Like he's like, I could see his brain working. And he was thinking like, this is what it is. Like he knew what it was, but when he seen it, it was like the excitement, and he was just like, there it is right there. You want to see it? It was absolutely, it was an experience. And I'm like, I knew I was not crazy. And I think just trying being my advocate for myself, because everyone just kept saying pretty much, I just felt like I was crazy. And I'm like, no, there's something wrong. There's something wrong. Like, this is not normal. This just does not happen to a 43-year-old. It just does it all of a sudden. So I knew something was wrong. I knew it was there was blood constriction somewhere. But nobody was listening to me. So I really, really appreciate Dr. Mannava.
And I would imagine that they would be sending you to psychiatry for anxiety and stress. We have so many patients. You were sent.
Yes.
Oh, wow.
Mm-hmm. Yep.
Well, let's focus on something positive, right? So he makes the diagnosis, but let me ask you this from a inquiring minds want to know as an interventionalist, were her tibial, or so were the
Yeah.
tibial vessels, so the branch vessels below the knee, were those occluded? And so the theory was she thrombosed them because of the constriction.
So great question. So you can have popliteal entrapment without showering clots to your foot and just have symptoms based on the entrapment. Or then it gets more severe where you've had clots, the artery gets so chronically damaged, or the repetitive trauma to the artery leads to clot formation. Well, the artery's healthy, so the clot, it's not hard plaque, it's soft clot. It breaks off the artery. And in Angel's case, it lodged both in her DP and in her PT at the ankle. And she had somewhat of a underdeveloped peroneal artery. So that's the reason she was having the ischemic symptoms in her foot, the color changes, the numbness, and things like that.
So how did you treat it? Because
Yeah.
and I'd love to hear Angel describe, the feeling of, having this situation fixed.
Dr. Mannava, which I don't know exactly which artery you had unclogged, but when he was in there doing the angiogram, I could feel the blood go through my foot. It was like a shower of blood finally being able to get through my foot. And I mean, it hurt at first, but they were like, well, it's because you haven't had blood in that area for some time. So yeah, one of them I think is still clogged up, and he's gonna have to fix that somehow once he does the surgery for the entrapment. But yeah, it was very interesting. It was so great. I came home and I was like, I can go to Kroger. I was like, I can walk in the store.
Well, coming up right here on the Heart of Innovation, we're going to find out exactly what the doctor did to fix it and how you can check with your doctor to find out if this is something that is ailing you. So stay tuned right here on the Heart of Innovation. Don't go away.
1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
All right, everybody, we are rounding third on this show, and excellent Save My Piggies. Thanks to Angel and Dr. Mannava for joining us. So before we went to break, Krishna, you had diagnosed the entrapment on the angiogram. You found out that several of the arteries below the knee into the foot were blocked. Sounds like you were able to kind of get through one of them, open that up. But at the end of the day, you have to release the muscle, right? You've got to do a surgical procedure to kind of allow the artery to breathe, so to speak, correct?
Exactly. So we made the diagnosis pretty quickly. And in Angel's case, I said, Angel, look, I'm going to go for it and try and get at least one of your arteries open into the foot to at least get you some symptom relief. But you have to remember, these clots down in the foot have been packed in for a long time, months. And so they're not easy to just suck out or extract. So, and sometimes you can make things worse when you are quote unquote mucking around down in the ankle. So anyway, so we took the chance, and it was a little painful, it was a little touch and go, but we were able to get her posterior tibial artery open and into the foot, and so that immediately gave her some symptom relief. We're going to schedule her for the popliteal entrapment release surgery, which is about a 90-minute surgery typically, where we go in behind the knee surgically, find the area that's entrapped, and release, typically if it's the medial head of the gastrocnemius muscle, release that, and then it frees the artery up. In some folks, hopefully it doesn't look like in Angel's case, her artery is healthy, so we don't have to do a reconstruction or a bypass of the artery, which makes it way simpler. In some folks I've treated, I've actually had to bypass the clogged popliteal artery, and that adds a couple hours to the surgery. But it can all usually be done through an incision behind the knee.
And is this something that there's some long-term durability? She won't have other problems down the road, or what can she expect?
No, it's amazing. So this is one of the few things we can treat that typically has amazing durability and can last her whole life, and
Yeah, you
prevent her from
basically
having this.
cure from it, right?
Yeah. And how often do we get that?
Yeah,
I know.
never.
And Angel, how are you feeling now? And what's your best advice for other patients that are in your situation?
Just be an advocate for yourself, because I mean, so many people, so many doctors were just, I mean, I had people just, the physicians, as soon as they'd be like, I don't know. I don't know. Like, wow, I've never seen this before. And there was probably 5, 6. I was admitted into the hospital for almost a week. And the vascular surgeon came in and said, oh, well, you don't have a pedal arch. And I'm like, I don't know what that means. And then I never seen a surgeon again. I was like, I have no clue.
Well, but so let me ask you, do you have normal pulses on the left? Which was the leg? The right leg was affected?
The
The
left was
left.
affected.
Yeah.
The left was affected. Do you have normal pulses on the right?
So there's some sort of occlusion on my right too, but I don't have any symptoms.
Huh.
Yeah, I mean, I can
strange.
palpate her pulses, both pulses on the right,
Oh,
John.
okay.
Yeah.
I mean, so like we talk about real quick, we talk about how simple the diagnosis could have been made very simply if you just examine the patient. And that's what we tell to our, doctors in training. Examine the
Yes.
patient. They will
Yeah.
tell you what's wrong with them. That's why this is like
100%. 100%.
mind-numbingly. I'm
Yeah.
glad you got to the right guy, though. That's good.
I know, I am too. I'm so thankful.
Yeah, and doctor, I'm curious, why would she have, that's interesting, because if it's just popliteal artery entrapment syndrome, why would she have it? Is there any issue? Have you looked into what's going on with the right leg as well, if she has some sort of occlusion
No.
down there as well?
She doesn't yet, but she has a risk of having popliteal entrapment on the right leg as well. So it's something we'll study in the future. It's not causing any problems now, but if she does have significant entrapment, it might be something that needs treated prophylactically.
Yep.
And this is something that, again, like peripheral artery disease, you don't want to treat it too soon. You want to make sure that, because it is something that it does take a lot to go in there, and surgery is involved. And anytime surgery is involved, there's greater risks. So you don't want to treat that too soon unless they do have those debilitating symptoms. Is that right?
As we're wrapping things up, what kind of medications do you have her on?
Angel already came to me on a blood thinner, on a full anticoagulant. So I've continued that because I don't want to risk clot forming until she has the surgery. Once she has the surgery, she shouldn't really need more than probably a platelet blocker.
And that too is a bit of a head
You've been
scratcher.
listening to The Heart of Innovation with Emmy Award-winning journalist.
Thanks for joining us, everybody.
And interventional cardiologist, Dr. John Phillips. Our mission is to help patients live a better quality of life through comprehensive education.